HHC Accountable Care Organization sole member annual meeting for calendar year 2023 is now called to order. So for the record, please note that Erin Kelly is representing the Deputy Mayor Ann Williams Heisel. Dr. William Fisher is representing Deepa Abdullah, and Karen St. Hilaire is representing Molly Wasso Park, all in a voting capacity. So next on the agenda is the adoption of the minutes of the HHC ACO annual membership meeting held on March 30th, 2023. Are there any questions, comments, or suggested changes? Hearing none, let me then call you for your vote. Dr. Kat, Dr. Calamia?
Yes.
Kelly?
Yes.
William Fisher?
Yes.
Tricia Martone?
Yes.
Karen San Hilaire?
Yes.
Sally Hernandez Pinheiro? Jackie Rowe Adams? Barbara Lowe? So minutes approved. Next on the agenda is a resolution for the annual election of the officers for the ACO. So Mr. Ziegler, please read the resolution into a record.
Absolutely. Authorizing that each of the following persons be elected effective immediately to serve as a director of HHC ACO Inc., ACO, Board of Directors in accordance with the laws of the state of New York, until such person's successor is duly elected and qualified, subject to each such person's earlier death, resignation, removal, or termination of his or her employment with any entity that has executed an ACO participation agreement or ACO agreement.
You might.
All the names.
I think it's fine like that. Do we need to read? It's fine like that. You can see the names here on the screen. Any questions or comments or? Okay, so let me then give you 1 second to look at it.
Here, just generally representatives of our major physician affiliation groups and our one key external partner, and then a Medicare beneficiary who is required to be part of the group and whose input we welcome.
So what's the status of the PAGNI?
It is likely to be Dr. Ed Chu, who's their president. They have not formally taken the step of appointing him to the board, but I think we can do that at our next meeting, which is in a couple of weeks, just at the ACO board.
So, any comments then? Hearing none, then let's take it for a vote. All in favor, please say yes.
Yes.
Yeah, both say no. So the resolution is approved. So Mr. Ziegler and Dr. Stevens will now provide an update on the activities of the ACO.
Well, thank you so much for the opportunity and great to see you all. As a reminder, our accountable care organization is a part of the Medicare Shared Savings Program, created in the Affordable Care Act as vehicles to bring together groups of providers to provide care under the Medicare program and to benefit financially when the care is provided less expensively than it otherwise would be in Medicare and certain quality measures are met. So it's really an overall effort to reform the Medicare program to be higher quality, lower costs, and build upon that across the U.S. healthcare system. And our ACO has really some of the greatest record of success in really the entire country. 10 consecutive years of delivering shared savings. We're the only ACO in New York State to do that, and one of only a handful across the entire country to do that. So it's a really proud legacy that this board has seen us through and supported throughout, and we're really grateful to keep carrying it forward. In 2022, we're anticipating distributing $8 million in performance payment. That's the shared savings amount that we earned by being more efficient than the traditional Medicare program would have been, and many of our regional counterparts were. So that will go out to physicians around the system and a care team fund to support quality improvement activities in different practices around the system. It goes to primary care doctors and really is a valued and important part of their compensation and driving quality improvement around the system. So that's excellent. You see the last few years of performance. This is one of our highest years on record. And it's particularly great to see that, kind of coming out of the COVID pandemic and seeing us bounce back in a great way there. We're very proud of that. Next slide, please. The big change in our performance this year that we're monitoring and thinking about is the federal public health emergency ended on May 11th, 2023. During the public health emergency, ACOs were not at risk to owe money back to CMS if we were not efficient in our care delivery. And so this year, if by some chance there are shared losses owed, they are prorated based on when the public health emergency ended. Similarly, during the public health emergency, COVID-19 costs were excluded from the calculation of shared savings. They will be included this year. And similarly, during the public health emergency, our quality scores were adjusted to take into account some of the disruption of COVID-19, and that will no longer be in place for the 2023 measurement year. However, taking all that into account, and we go jumping to the next slide. As we've monitored it so far this year, we do project that we'll be able to have our 11th consecutive year of shared savings and will not owe money back to CMS. We update this quarterly and then monitor our performance on hospital admissions and other utilization on a daily basis. But it does look promising. We don't guarantee anything until the year is over because there are adjustments at the end of the year, but we feel very good about where we are. And so that is another badge of honor for the team as these rules have moved back to what they were pre-COVID. So we're very pleased to see that. Next, please. The big step in the year ahead, probably between the time of this meeting and our next meeting with the full board, we will have decisions to make about updating our contract and extending our participation in the overall ACO program. The federal government under the Biden administration has indicated they continue to be committed to the ACO program. They're finding new ways to encourage people to participate in it and to make it more attractive for rural providers, for providers that treat lower income patients. And we've had discussions with people at the highest levels of the federal government about what we see as opportunities in the program. And so we will have a recommendation for our board at the ACO level and share it with this board on how we propose to proceed. I think we've been successful in it. It is a valuable part of our overall value-based payment approach around the system. So I anticipate we will continue it, and we'll just lay out folks the options that are on the table and before we make that decision. But that is coming up in the year ahead.
Matt, is there movement federally to try to tie performance to how a system handles all of its patients under this program?
Yes.
So from the quality metrics specifically,
Right.
The chronic disease metrics of diabetes control, hypertension control, and depression screening and linkage to care, the denominators for those are the entire population.
Okay,
Meaning
so
people on Medicare Advantage and Medicaid?
And everybody we treat, everybody who walks in the door.
I mean, that's currently, David, right?
Not,
Or
not-
that's proposed. I just remember reading it and I couldn't remember in what context. I mean, I think that's a pretty powerful tool then, to the extent that CMS can get people to participate, because, right, the thing we've always thought of this program is we are proud of taking care of everybody the same, right? We have never wanted separate pathways. We want to take great care of everybody. And we don't know who's in this program. I have patients in this program, but I don't know who they are. And that seems great to me. And to the extent, since these patients represent a small part of our overall volume, or any system's overall volume, to the extent that it was all pegged to quality for all of the patients, I would think we would do better than other institutions, which I think are more likely to distinguish among their patients. in terms of how they approach them. So I see it both as a potential advantage that we have over other systems that have the multiple tracks. And also, it just seems to me a more powerful tool that the federal government could have over everybody's healthcare if it would work out that way.
Yeah, I mean, I think that's probably true. Participation in the ACO program is, I'd say, stabilized, right? It is about 15 some odd percent of the Medicare program. That's been a pretty steady number. Medicare Advantage overall has grown much more rapidly. And, you know, the quality component of the ACO's financial calculus for folks is relatively small, and the financial benchmarks are still set off of this cohort of traditional Medicare patients. But I agree. I hope they stick with the policy, and I hope it isn't discouraging to others who might want to consider participating. CMS's overall goal is to have everyone in the Medicare program in some form of alternative payment model, of which an ACO or different innovative Medicare Advantage programs would count by 2030. And so they are balancing how to make the programs meaningful and, you know, really driving quality across the population with moving people out of the kind of more traditional, just pure fee-for-service Medicare program. So they are balancing it, and it will be a question of whether they stick to this.
What percent, Matt, of Medicare these days is Medicare Advantage approximately?
About 50.
About 50.
51, yeah.
Is
50.
that at our facility? You mean nation?
Our facilities, I have to check that number. I think we're close. It's in the 40 to 50 range.
That's not bad.
Both nationally and with us. It's getting up to that tipping point.
I had a very quick question. First, congratulations on tremendous track record and serving as a training model for so many others. I know that the methodology was changed on the quality metrics, and I couldn't remember, did they increase the rate you needed to have to pass on all of them? Did they change some? Did they add them?
Thanks. So the percentage that you see is the percentage of total points available that we achieved. It's not in comparison to a benchmark. During the public health emergency, two of the metrics, everyone just automatically got the top score, or essentially the top score. So everybody's went up and everybody sort of came down. So our performance in the individual metrics compared to our peer systems are either the same or improved. But just that number of eligible points that we
Right.
achieved went down just because they didn't give us any for free.
Thank you.
Go ahead, Barbara.
I'm just concerned about their increased interest in our highest risk populations and how well we do with them. And I'm beginning to see some evolution of that in the metrics that they are looking at and how they policies, risk, and so forth. We've done very well, however, but we need to keep our eyes on that.
Absolutely.
You know, in our copy and everything else, of course, in our daily practices, and make sure that our providers are up to speed on all of that as well. The documentation we've done very well so far.
Yeah.
And hopefully we will continue. But when I look at what they're doing with the federally designated centers, they're really whipping out some metrics there. And so I know we will continue to do well. We have
Well, yeah.
doing this work, of course. But I think the sensitivity should be there.
Thank you, Barbara. I think that's important.
And it's a very relevant point for the ACO because the membership in the ACO is not growing, right? The membership in the ACO is steady, if slowly declining. And the population we see is, you know, I'd say generally older, frail, and less attractive to plans marketing Medicare Advantage and growing that membership. So it is something that we watch out for. Is our risk pool going to get sicker and more vulnerable.
One of the odd things, and again, this is beyond the presentation, but this is a policy group. In some ways, the way the world is going at the moment, if you're rich, someone would tell you to do fee-for-service Medicare. And if you're not rich, they tell you to do managed Medicare, right? And the difference would be if you're rich and you don't have to worry about, what your, percentage is. You go to any doctor you want. Every doctor accepts you, right? It's the 80% is covered and you're done. And you can afford the 20%. And so you maximize your access and it just costs you some dollars. The big advantage of the Medicaid Advantage programs, which ACO doesn't really do, is glasses, right? Hearing aids and other kinds of things that if you're low income, you might really appreciate. Because you might not be able to get yourself the $2,000 hearing aid, right? Which then sort of raises a little bit of the question in my mind about sort of what is our responsibility to our patients, right? Should we in some way, I mean, ultimately they decide, right? But do we have some responsibility to telling people, if you signed up for an Advantage program, they cover your hearing aid and glasses. So I don't, I sort of, I wonder a little bit about, as this all goes forward, how do, our job should be to ensure that our Medicare patients are getting whatever is best for them. Again, they choose. Our only job would be to try to make sure that they had the information to make the best possible choice.
Yeah, it's well taken. I mean, I think there is no ACO marketing booth, right? And there's no enrollment
Correct.
in the ACO. It's kind of prospectively assigned based on who is enrolled and stays in.
I'm sorry, could you just, how are people assigned to the ACO? Is it?
They're assigned based on their recent historical utilization, right? So do they come to our system and see primary care doctors and primarily use us as their medical home? And are they in the Medicare program?
Fee-for-service Medicare.
Fee-for-service Medicare.
So, right. So the way, again, just because we are a big policy group, the history of this is the CMS wanted everybody in managed care Medicare. But that wasn't politically acceptable to force seniors into a managed care plan. So this was sort of the compromise. Okay, well, if you don't want to go over here, what we're going to do is we're going to try to manage your risk and your care in this ACO. But you won't even know that you're in the ACO. No, absolutely not. And we wouldn't want them to. And the way you get assigned was based on whatever you were doing. So when the idea was, well, we're not inconveniencing you. If you're in our ACO, you have the same rights as any fee-for-service patient to go wherever you want for whatever you want. Mm-hmm. But the idea of this was, but if we, the system, know you're in our ACO, if we know that Frida's in our ACO, we're going to try to reach out to her and say, oh, Frida, instead of going to these emergency rooms where you're having these difficult experiences, what could we do to help you? So that we would effectively drive down your costs, because the assumption is the ability to go anywhere you want, whenever you want, right? There, unlike what most of us are used to, there are no referrals in Medicare. You don't need anybody's approval. You want to see a neurosurgeon? You make an appointment with the neurosurgeon. If they take Medicare, you're set. Doesn't matter if you want to go to see the neurosurgeon because you had a headache 3 years ago. If the neurosurgeon will see you, you get the appointment.
So why would our ACO membership be dropping?
But we Medicare Advantage, we market aggressively, and
because
plans
they're
market
moving to
aggressively.
Medicare Advantage, so we have fewer ACO members.
But that's the move.
The proposed change would bring in Medicare Advantage as well?
Just
Or
to the
not?
quality metrics.
Just to the quality.
The diabetes, hypertension, and depression control quality metrics that we must meet to even be considered for shared savings.
Hmm.
Currently, they're just looking at our ACO membership. How are we doing with hypertension in our ACO membership? The new metric would, just the quality metric, we would be accountable for the entire population that we treat.
But Mitch, your point on should we be encouraging people more to Medicare Advantage or just for the appropriate reasons? Why would it, if they're getting the care that they need?
Because Medicare Advantage in exchange, if I say to you, Frida, I'm going to constrain your freedom,
Correct.
where you're going to go, but in exchange, I'm going to give you access to hearing aids and glasses, which are not Medicare services. Then Frida makes a decision. Would I rather the freedom to go and I'll pay for my hearing aid? Or would I rather accept a smaller network and some more constraints in exchange for getting the hearing aid?
Right.
And the general consensus in the field is that if you're rich and you don't care, be in fee-for-service, go wherever you want, no interruption in your access. But if you're someone who might need a hearing aid and not be able to, hearing aids are $2,000 minimum, then you should be in
Yeah.
a
Medicare doesn't
Medicare
cover
Advantage.
a $2,000 hearing aid, right?
Absolutely not.
Advantage.
Medicare
Oh, the Advantage. I don't know what,
I think it's
I don't know
like
which
$600
ones they
or
cover.
$400. I mean, let me put it this way: the benefits aren't rich.
It's an ear trumpet, like.
Please, go ahead.
So a lot of people in fee-for-service Medicare also have some kind of med sup policy. It seems to me that the ACO is not only saving the ACO members, the ACO organization money, it's saving those med sup insurers money. And is there anything in the program that tries to recoup some of that savings from the med sup plans? Because if your Part B costs are going down, your med sup costs are going down.
Interesting. I haven't seen it analyzed at that level in that way. I mean, I think, the overall goal here is net savings to the Medicare program writ large. But that's an interesting question about the specific supplemental programs. I don't know. Happy to look into it.
It sounds to me that we're getting ready to talk about maybe holding a couple of focus groups with our providers and others to get some input on this, because there are other changes that will be piggybacked on this, clearly. I mean, every day I turn on the TV, there's more in government that's threatening and has to do with finances that impact communities.
We'll keep our eye on it.
Yeah, and maybe there are some whippersnapper, providers who have the bright ideas for us, and maybe some of our clients as well.
Very good. Thank you, Bob.
Great. Well, we have the bulk of our presentation. I know we have only until 2:00. The bulk of the presentation talks about a lot of the quality innovation that we're doing. And we really do view the ACO as a kind of laboratory for new investments and new efforts to drive quality and value. And then if we find things that work with our ACO population, we try to spread them around the system. So maybe pick out a few of the key things we're working on and call out the slide.
Yeah, slide 13. This is the work that we're doing specifically on the sickest of our older patients. We've found that if we look at patients who have had 2 admissions over the course of 12 months, that is a chronically severely ill patient who is likely to have further admissions and likely not to be getting the best quality outpatient care. So we're very focused on that group. We engage our primary care teams within a week of that patient's discharge. They reach out to the patient, make sure they're engaged in the right care, whether it's specialty care or primary care. They bring in community health workers. We're pretty happy about that. Sorry, I turned you to the wrong slide. It's actually slide 14. I said all the right things, but with the wrong slide. Slide 14. Yes. So we want to make sure every patient gets a 3-day follow-up call by somebody who can assess their symptoms, make sure they're not getting sick again, and make sure they're getting their medications, 7-day appointments with Ideally they're PCP, or somebody else in the practice, and the community health worker referral, because again, this group of patients who have had 2 admissions inside of a year almost always have social barriers to taking ideal care of themselves. And a community health worker can often be the single most important thing we offer them. That's one pocket of work. And over the year, we've expanded the scope. We started with the ACO patients, then we've added the other value-based programs into that. And we're close to being able to add all patients who meet that criteria. And then, couple slides, 12. Slide 12 is heart failure, the single biggest condition driving hospitalization, and probably the single condition where we can make the most impact by improving the outpatient care is congestive heart failure. It's the #1 cause of readmission throughout our system. And what we found that there are standards of outpatient care that if universally made available to all our patients, regardless of where they get their care, our ability to optimize their symptoms, make them feel as good as possible, and keep them out of the hospital, all that goes up. And so we've been working with each of our facilities to make sure they are able to deliver that care. That's not a ACO focus, ACO members focus. That's for all patients with heart failure across our system. We're motivated to that because it costs the ACO a lot of money, but it's a problem for all of them. Those are the 2 areas I wanted to highlight.
From board members? Question connected to this. Okay, I'm going to go back to the beginning, which was how we elected the board and all of that for the ACO, right? Which is because ACOs are moving more towards social services and social determinants and things like that. Do we have any way of having more voices from that area in the ACO, or is it something structural that we already in our bylaws of the ACO say we only take 6, 7 people, only 1 person is a Medicare beneficiary? And because I think that colors, of course, the strategies that you propose, which are great. And I'm not trying to say you've been done great for 10 years, right? I mean, 10 years, is it 10? So, but given that Medicare is moving towards the social side, I don't know what the right mix is, but community organizations or non-clinical voices may help. So just something to think about.
Well,
Yeah.
I would agree,
Yeah.
but I'd also say, but that's also this board's function.
Yeah.
Yeah.
Right, I mean, that's why this board has 5 members
Yeah.
appointed by members of the city council, as
Yeah.
well as, the agencies of city government, DOH, the Department of Social Services, right, are all here as well, so.
We have other layers. We have the community advisory.
Right.
as well.
So,
Yeah.
But the day-to-day, right? Because we don't get involved in the day-to-day.
no,
of the
fair,
ACO, yeah.
fair.
I will review our bylaws. If I recall, I think it was a pretty structured and
Yeah.
delegated thing of which affiliates, how many people get what number of votes. But I think it's a great point, and certainly the members of the Health and Hospitals leadership team who are on it and spend their time on the board, we'll try to orient that
And I
direction.
bring it up not because of our ACO, because I think we have a great ACO. I mean, one of the best ones in the country, if not the best one. This is a structural problem of the ACO program, I think, that when it was designed that way. But I always wonder, like, if is it possible you have some leeway on that,
The point is, it was designed to save dollars.
It was
It was not
designed-
designed to meet social needs, but now,
And now it's changing.
Needs to change.
I mean, it was designed for clinical care to save money, so the solutions tend to be clinical.
Uh-huh.
That's what I mean.
Yeah.
okay,
Anyway,
I think there's, in this group of population, especially the older, frailer, multiple chronic illness, there's pretty good alignment between saving money and helping them feel better.
yes.
Because it's keeping them out of the hospital, keeping them out of nursing homes, keeping them functional.
okay, I think we're done, right? So any old business or new business to come before the this board? Well, this organization. Hearing none, the meeting is adjourned. Thank you so
Thank
much.
you.
Thank you.
Thank you.